Good evening, doctors. It's indeed a great pleasure to welcome you all this evening for this webinar, which has been having the best of the faculties of the country. It's a great honor to have the faculties who are great academicians, who are great contributors in the respective field of cardiology and endocrinology. And we are at IPCA very delighted to have them today with us. And it's definitely going to be a very great academic feast to all the doctors who are attending to this webinar. So at the outset, it's my great honor and privilege to welcome the moderator for the sessions today, that Dr. Sivakadaksham, who is a senior interventional cardiologist, Siva's Cardio-Diabetic Care Clinic from Chennai, who is a great academician, a great orator, and he was an ex-professor of the cardiology from the Stanley Hospital, Chennai, Stanley Medical College and Hospital. He has presented various papers at international meets and conferences, has a lot of credentials, a few articles which was published in the national and international journals in the field of cardiology, has been a faculty to more than 500 academic events across, and has been instrumental in organizing various patient awareness and education initiatives. Has been a recipient of the Indian Science Monitors Doctors Day Award in 2008, and also a recipient of the Tamil Nadu Dr. MGR Medical University Best Doctor Award in 2011. And he was also a recipient of the Rotary Club of Chennai Towers Lifetime Achievement Award in 2013, and has been a part of the various organizing committee towards better healthcare services. It's a great honor to have Dr. Sivakadaksham with us. So welcome to the shows today for the webinar. And we also have Dr. K. Narasa Raju, who's another senior interventional cardiologist from Yashoda Hospital, Somajiguda, Hyderabad. He has been associated with various cardiac institutes in Hyderabad as a senior interventional cardiologist, like Max Cure, Apollo Hospital, Sunshine, etc. He was also practicing coronary peripheral structural heart disease interventions as a primary operator. He has been instrumental in researches and publications in the field of cardiology, serving as a faculty in various national and international CMEs, has been an examiner and academic counselor for DNB cardiology students and the PGDCC students, serving as an active core committee member of the Lipid Association of India, has contributed for the framing of Indian guidelines of dyslipidemia management, and has been an author for a chapter on lipidology update published by APA in 2016. And the topic for today, for Sir, who's going to talk about is has chlorthalidone been an underutilized in the hypertension management? And we also have the eminent endocrinologist of the country, Dr. Bipin Kumar Sethi, sir, with us, who's a consultant endocrinologist, head HOD of the Endocrinology Department, Care Hospitals, Hyderabad. He has been a life member of the Endocrinology Society of India, has been a life member and Faculty Research Society for the Study of Diabetes, the RSSDI, a visiting faculty from the National Institute of Nutrition, Hyderabad, and 3 decades of teaching experience in the field of endocrinology. Sir has been also an instrumental in research work and various clinical trials in the field of endocrinology. And Sir has also published various articles in the national and international index journals. Dr. Bipin Sethi has been awarded with Economic Times Inspiring Doctors of India in 2018 in New Delhi, has been a faculty and speaker to various academic events, and Sir has also won the silver medal for standing first in academics from PGH Chandigarh during his medicine days. And Sir is going to talk again about a very, very interesting topic, that's what is sacrosanct about the HbA1c target of 7. And with this, I hand over the sessions to Dr. Sivakadaksham, sir, to take over. Sir, over to you, sir.
Thank you, Johnny. And it is nice that IPCA is connected with us in bringing out this wonderful academic session. One topic in cardiology, that is the most common non-communicable disease, hypertension control. And the second most common non-communicable disease, that is diabetes. That is about the control of diabetes. Now, to deliver the first lecture on the chlorthalidone, as it been underutilized in the treatment of hypertension, we have the eminent interventional cardiologist, Dr. K. Narasa Raju from Hyderabad, Yashoda Hospital, and he is going to tell us what is the role of chlorthalidone can it be increased in that usage? Now, when we talk about treatment of hypertension, majority has been told only about A, B, C, D. And when it comes to Western countries, most of them do not use beta blocker, that is B, because they are against it. Even though Southeast Asians and blacks, they respond very well to hypertension control with beta blockers. And beta blockers in the Western countries is used only in hypertension associated with myocardial infarction or angina and other things, coronary artery disease. But the most commonly used is ACE inhibitor or ARB and calcium channel blocker. Now, it is a very well-known fact that when you want to achieve the maximum effect of either the ACE inhibitor or the calcium channel blocker, an addition of a small dose of a chlorothiazide or a chlorothiazide-like diuretic called chlorthalidone is supposed to produce a wonderful control of blood pressure. Now, when we had JNC 6 and JNC 7, we used to have what is called a step-wide treatment, and the step 1 treatment would be using a diuretic. Now, in the past 10 years, we are selecting chlorthalidone rather than chlorothiazide. The reasons we are going to hear from Dr. Narasa Raju, why chlorthalidone is preferred over chlorothiazide. So he is going to tell us, is it because the number of studies are more, documented studies are more, or is it because the side effects are less, or it is the duration of action is more? All these things we are going to get it from the horse's mouth, and Dr. Narasa Raju to explain to us why that should be used more than what it is being used. Are we underutilizing the chlorthalidone treatment in the area of hypertension therapy? Thank you, Narasa.
Thank you, sir. Thank you for the nice introduction. At the outset, I would like to thank the organizers, IPCA, for giving me the opportunity to connect with you all and share a few thoughts of hypertension management with you. And of course, we all learn with each other's interaction and discussion. I request all the participants to actively participate and be active, and whatever questions that you have, maybe put as in the chat box, and we will try to discuss all those issues. We have eminent speakers, and a good evening to all the participants, and also to my the moderator, Dr. Sivakadaksham, and also to Dr. Bipin Sethi. And the topic that I am going to talk about today is the one which is a very important and relevant topic for us in the management of hypertension. That is the role of diuretics, and especially with regards to the diuretics, the chlorthalidone. With regards to the chlorthalidone, as Dr. Sivakadaksham already briefed, we know that diuretics form an important part of hypertension management. In fact, the definition of resistant hypertension is only after we have tried using a diuretic. So among the diuretics, it's not that the loop diuretics are also coming into hypertension management. It is only the thiazide diuretics or the thiazide-like diuretics. And predominantly we have in our clinical practice, we have three options: the option of adding chlorthalidone, or the option of adding hydrochlorothiazide, or indapamide. So these are the three options that practically when a physician wants to manage hypertension, that's the three options that we have. Among them, it's unfortunately finding that chlorthalidone has been underutilized. There are various reasons, and in fact, if we look at the history of thiazide diuretics were introduced into hypertension management about 5 decades ago. In the early 60s itself, we had evidence that hydrochlorothiazide and chlorthalidone are good antihypertensives, and chlorthalidone was used in the 70s, but from 70s onwards, its use has declined drastically, and it's taken over more by hydrochlorothiazide for various reasons. And of late, we have realized that chlorthalidone, which is a very, it's a very good antihypertensive, and it's in fact a better diuretic as a diuretic antihypertensive compared to hydrochlorothiazide, and we started using chlorthalidone. So we'll look at all those issues and the issues of chlorthalidone underutilization, and why we should increase the usage of chlorthalidone in the hypertension management is the topic of today's discussion. So looking at the history of chlorthalidone, hydrochlorothiazide in fact was approved, the first one to get approved for hypertension management in the year 1959. In fact, I was not born by that time. Chlorthalidone in the year 1960. So these are almost simultaneously they were approved in the hypertension management. There were, and then there were trials which were conducted with both the agents, and both the trials documented equal efficacy in the early phase in terms of antihypertensive efficacy of hydrochlorothiazide versus chlorthalidone in very literally small doses. In fact, the doses that we use these diuretics, we are not using them as properly as a diuretic. We are not trying to achieve any kind of diuresis when we are giving. We are giving very small doses. In fact, at those doses, they are not properly, not diuretics in the true sense. In the utilization of the diuretics in hypertension, the first landmark trial was the MR-FIT, Mr. Fit trial, which started somewhere in the June 1972 and went on for about 26 years to almost July 1998. So we have a very good data in terms of hypertension and the usage of chlorthalidone and hydrochlorothiazide from MR-FIT trial. MR-FIT trial basically looked at young men who were aged 35 to 57 years. They were for various risk factors. Those who had no CAD, without CAD, with risk factors, they were randomized to various arms, one of the arms being the hypertension arm where diuretics were used. So in the MR-FIT trial, there were 15 participating clinics. In the choice of diuretic was in fact left to the clinic. So here about 9 clinics chose to use hydrochlorothiazide and 6 clinics chose to use chlorthalidone. That's the MR-FIT data. And when we got the data is like this. So as you can see from the slide here, when we look at clinical MI and ECG MI, and also the Rose questionnaire for angina, they were significantly better in the arms which received in these clinics where chlorthalidone was usage was there, in comparison to hydrochlorothiazide. So the p-values, as you can see from the right side of the slide, you can see that the p-values are significant for clinical MI, ECG MI, and the CABG and Rose anginas, the questionnaires as well. So the conclusion from the MR-FIT trial data was that the patients who were the participants who were receiving hydrochlorothiazide were faring worse in comparison to those who were receiving the chlorthalidone. And in the trial itself, people were the clinics which were receiving hydrochlorothiazide were recommended to switch to chlorthalidone because of the trend in improvement of mortality. So this is the first evidence that chlorthalidone in comparison to hydrochlorothiazide fares better when it comes to hypertension management. But then the same principle was proven in 3 large controlled outcome trials. One is the SHEP in 1991, where the prevention of stroke by antihypertensive drug treatment. And then we have data from the verapamilin hypertension and atherosclerosis study that's published in 1997, and ALHART, the famous ALHART in 2002, where chlorthalidone in these 3 large controlled outcome trials, chlorthalidone provided excellent protection against MI and stroke, giving a strong evidence for chlorthalidone being a better diuretic when it comes to hypertension management in comparison to hydrochlorothiazide. But when the data was coming out like this, still the hydrochlorothiazide outsold chlorthalidone when you look at the market data. The sales of diuretic hydrochlorothiazide always outsold chlorthalidone. Probably the reason is because of this, that in 1964, as we saw in 59 and 60, when both the diuretics were approved, in 1964, Veterans Administration started a hypertension treatment study. And when they took diuretic for their study, they chose hydrochlorothiazide, and then the hydrochlorothiazide became like one of the drugs for hypertension management. Probably because of this reason, hydrochlorothiazide got added in combination to various antihypertensive drugs, and there are varieties of combinations. Except with calcium channel blockers, it's combined with almost all the diuretics, almost all the antihypertensives, including a beta blocker. So we had, in fact, I remember having seen a combination of beta blocker with hydrochlorothiazide. I think still it's there in the market. So, after the initial success, chlorthalidone, progressively the usage from the doctor side has fell down, and it's combined only with three classes of antihypertensives. But that was the scene up to the early 2000. But in 2004, we started getting more and more data, which started proving that chlorthalidone is a stronger and better antihypertensive in its antihypertensive efficacy over hydrochlorothiazide. And this is one of the articles which looked at the comparative antihypertensive effects of hydrochlorothiazide and chlorthalidone on ambulatory blood pressure monitoring. And what it basically looked at is giving both the diuretics, chlorthalidone in the dose of 12.5 milligrams per day, force titrated to 25 milligrams per day, versus hydrochlorothiazide 25 milligrams per day, force titrated to 50 milligrams a day. When it was looked at, within these recommended doses, the chlorthalidone was more effective in lowering the systolic BP, and by the 24-hour ambulatory BP recordings. So this actually is another important thing, because of the longer half-life of chlorthalidone. Chlorthalidone exerts more effective lowering of systolic blood pressure throughout the day in comparison to hydrochlorothiazide. So chlorthalidone was compared with hydrochlorothiazide in the systematic review of all the randomized control trials of hydrochlorothiazide and the RCTs of chlorthalidone. When they were systematically reviewed, there were about 3 RCTs of HCTZ. That's about 18,000 odd patients in the hydrochlorothiazide group, and about 59,000 odd patients, nearly 60,000 odd patients in the 6 randomized control trials of chlorthalidone. When both were analyzed by this analysis, which is published in Hypertension, there was about 23% reduction, risk reduction for CHF with chlorthalidone versus hydrochlorothiazide, and about 21% risk reduction for the cardiovascular events for chlorthalidone versus hydrochlorothiazide. So we have now sufficient data which proves that the chlorthalidone is a better antihypertensive in comparison to hydrochlorothiazide. The BP lowering potency is about 3:1. That's probably one of the reasons we thought we were looking at the 24-hour ambulatory blood pressure monitoring and deducing that the superiority is because of its longer half-life. And the other reason why chlorthalidone is a superior antihypertensive is probably because of its BP lowering potency being about thrice in comparison to the hydrochlorothiazide. So as you can see here, the dose that is required to reduce systolic blood pressure by about 10 millimeters of mercury in chlorthalidone is about 8 or 9 milligrams in comparison to 26 milligrams when it comes to hydrochlorothiazide. And to reduce the BP, the diastolic blood pressure by 4 millimeters, you need just 14 milligrams of chlorthalidone in comparison to 20 milligrams of hydrochlorothiazide. So the routine practice of giving about 12.5 or 6.25 of chlorthalidone is a very good option according to this data. This is the 24-hour BP control data with chlorthalidone and hydrochlorothiazide. As you can see here, the office systolic blood pressure and the 24-hour SBP and the nighttime BP. As you can see, the arms which received chlorthalidone, which are in the blue, had a superior, systolic blood pressure reduction in comparison to chlorthalidone, which is also evident in the graph here. So chlorthalidone, we have seen that there is a data like this, and what are the international experts and the textbooks saying? If you look at Braunwald's textbook, which is the Bible for any cardiologist, it says either indapamide or chlorthalidone is likely would have produced a better CV protection than hydrochlorothiazide, which was used in Accomplish. That's the actual sentence given in Braunwald's heart disease textbook. And given the absence of outcome data with hydrochlorothiazide and benroflumethiazide, their use is not recommended for patients with or without diabetes is another statement that you find in Braunwald's textbook. So it also says the meta-analysis of all the randomized controlled trials support chlorthalidone and indapamide in the treatment of patients with diabetes and not hydrochlorothiazide. In fact, we see many patients of diabetes getting an ARB or an ACE inhibitor in combination with the hydrochlorothiazide. I think that practice should change over to a combination with the chlorthalidone. Regarding the international experts' opinion, Dr. Norman Kaplan in his book also says, in the article in Hypertension 2011, he says, chlorthalidone is the best diuretic for the treatment of hypertension, both in BP lowering efficacy and also in the prevention of hypertension related morbidity and mortality. And he says, despite this fact, hydrochlorothiazide has been and continues to be the most frequently prescribed diuretic, and which is a practice which should be changed. Similar opinion is also echoed by Dr. Franz Nesserelli, who says hydrochlorothiazide has no published evidence to reduce heart attack or stroke, and because of its short duration of action, it fails to act as an antihypertensive in the night and early morning hours. See, the patient typically takes the hydrochlorothiazide combination in the morning, and the next day morning, early morning hours or in the night, it loses its antihypertensive efficacy. So there is always an increased chance of having hypertension related complications or increased hypertension in the nocturnal reading, which is actually what we saw in the 24-hour ambulatory recordings. So in fact, it gives a false sense of security because the patient goes to the doctor and the office blood pressure would be in the normal range. So use of chlorthalidone is also recommended by guidelines. The Indian guidelines published in 2013 and 19, chlorthalidone is preferred over hydrochlorothiazide as an antihypertensive. And in the ACC/AHA guidelines in 2017, you can see in the comments, chlorthalidone is preferred on the basis of prolonged half-life and proven trial reduction. And but only thing that we need to do when we are using chlorthalidone being a superior diuretic, it tends to produce more hyponatremia and hypokalemia. That's in fact my personal experience also, that chlorthalidone tends to produce hypokalemia. We have to watch out for that. Hyponatremia, especially in the elderly people. And in the ACC/AHI, also again thiazide diuretic, especially chlorthalidone or CCBs are the best drug initial for patients with stroke. So the meta-analysis as well as the largest ACC/AHI says, the meta-analysis as well as the largest individual RCTs compared the first agents for suggested the diuretic, especially the long-acting, the thiazide type diuretic, chlorthalidone would produce an optimal choice for the first step therapy for hypertension. So chlorthalidone is more potent than hydrochlorothiazide, and for milligram, it's more potent in terms of milligram to milligram versus hydrochlorothiazide. There is no clinical or trial evidence of greater incidence of side effects, but I beg to differ here because I saw, in my opinion, I saw more hyponatremias and hypokalemias with the chlorthalidone switchover. And I always keep a watch on these two, especially when they're elderly, and act accordingly. So the recommendation of chlorthalidone from the ESC/EHS ESH 2018, they recommend the thiazide type diuretic, and chlorthalidone and indapamide are preferred as the initial choice among this. So chlorthalidone in specific conditions, resistant hypertension. So resistant hypertension, as I said in the introductory remark itself, it's defined only after we have tried a diuretic, then the blood pressure is still not optimally controlled, then only we call it as a resistant hypertension. So in all resistant hypertension, before, I mean, when there is a patient who is having higher pressures, even with a calcium channel blocker or a RAS blocker, thiazide diuretic has to be added. And in the stroke management also, the thiazide or thiazide-like diuretic is recommended by guidelines. The clinical efficacy is supported by the clinical efficacy and safety is supported by evidences like, as you can see here in the ALHAT trial, among the three groups, chlorthalidone, amlodipine, and lisinopril, the group which received chlorthalidone had the highest reductions of the SBP. Mean blood pressure. And then regarding the heart failure and CV events reduction, there's as you can see here, the relative risk, among the three, amlodipine versus the chlorthalidone tended to favor the usage of chlorthalidone. As you can see from the Forrester plot, the evidence favored chlorthalidone in terms of combined CV events as well as in the heart failure. So the key benefits with chlorthalidone, it reduces the total stroke by 36% in the SHEP trial. And so in the LHAT, as I just mentioned, among the 22,000 odd participants, chlorthalidone had the lowest hazard ratio for CV mortality, for non-CV mortality, CHD and stroke in the patients, among the patients who developed diabetes, incident diabetes. So hypokalemia, there is, of course, as I said, in practice, we see hypokalemia and hyponatremia with chlorthalidone, but this is actually a marginal 0.2 milliequivalents per liter loss of potassium over 4 years. And among the hyponatremia data from SHEP, it's about 0.9 milliequivalents per liter loss of sodium over 1 year. So among the other concern that we have with the diuretics is the concern of hyperglycemia. There is a marginal increase. Actually, in fact, diuretics are one class of drugs which can, make diabetes, incident diabetes happen, especially in somebody who's prone to have to develop the diabetes. And there is a marginal increase of about 3 milligrams per deciliter over 4 years is what we saw in the LHAT trial. So the many experts, even in fact from the textbooks, there is a concern that chlorthalidone, though that has a lot of trial data and superiority in comparison to hydrochlorothiazide, there's an underutilization, and that's a growing concern. So I come to my conclusion of the presentation. The chlorthalidone came into practice along with hydrochlorothiazide in the early 70s, but its use has dropped drastically over the last 20 years for various reasons. One of them being the veterinary affairs trial choosing to use hydrochlorothiazide rather than chlorthalidone for its trial. But the variety of evidence, as we have seen, clearly proves that chlorthalidone is a superior diuretic as a choice for hypertension management in comparison to hydrochlorothiazide. And that's in fact recommended by the various textbooks and by various international authorities and the guidelines. So I think we should, when it comes to practice, we should take it as a message that we should try to keep our patients on chlorthalidone. Of course, we need to keep watching for hyponatremia and hypokalemia, especially in the elderly. Thank you. Thank you for your participation and, for actively, I request all of you to actively participate, and any comments and anything to be discussed, I welcome all of them. Now over to Dr. Sivakadaksham.
Thanks, Narasa Raju, for the wonderful exposition of the usage of chlorthalidone, how it is a must. Beautifully, he highlighted the points that it is long-acting, less side effects, less hyperglycemia, less hyperuricemia in the dosage that we use, lesser dose than hydrochlorothiazide, And long-acting, therefore, he showed the beautiful curve in the ambulatory blood pressure monitoring that it is able to control the night increase in blood pressure. That is nocturnal. In many hypertensive, instead of nocturnal dip, you get the reverse dip. It increases in the night. That is also being controlled by chlorthalidone. So there is more than one reason to use chlorthalidone. And we will take a few questions before we move on to the diabetology. One of the questions is from a very leading cardiologist of Chennai who takes part in many of the academic things and in many of the trials. He is Dr. Abraham Oman has asked a wonderful question. Chlorthalidone or indapamide? Your comment. I will tell my comment and then I will ask for Narasa Raju's comment. My comment would be west of Atlantic, people use chlorthalidone, and in Europe, people use indapamide. Because indapamide is not a molecule that is available in the USA, and therefore they are comfortable with chlorthalidone. Now we have the best of both worlds. We can use both. But I would agree with Narasa Raju in this, whether you use chlorthalidone or indapamide, if you are not going to use along with, I mean, I'll come to that later, if you have to be very careful about hyponatremia. There are many of my colleagues who have told me there is more hyponatremia with indapamide in the long-term usage. And Narasa Raju has very clearly pointed out that even with chlorthalidone, there is hyponatremia. Over to Narasa Raju.
Yeah, that's a nice question from Dr. Uman. And, in fact, when it comes to, choosing either of them, indapamide versus chlorthalidone, I tend to choose more often, chlorthalidone. There are two reasons. One, chlorthalidone has, more trial evidence, and it's there in the diuretic usage. As a diuretic, we have been using it for a very long time. In fact, all the major trials of diuretics are with chlorthalidone. That's one. Two, in combination with, the conventional ARBs or ACE inhibitors, we have chlorthalidone rather than, the indapamide. Indapamide has, in combination, some companies are producing in combination, but I tend to use, an ARB or an ACE inhibitor in combination with chlorthalidone most of the times. So my choice usually is with chlorthalidone. I don't have anything against, indapamide as such. Indapamide as a single agent I use in some patients, but in general, my choice is chlorthalidone. There's no head-to-head comparison of indapamide and chlorthalidone to my knowledge, and I don't see any difference between the two as such. If I'm open to
I agree with Narasa Raju, and a combination of ARB or ACE inhibitor with a chlorthalidone would be a better choice to avoid a hypokalemia, because one is going to raise the potassium, the other is going to reduce the potassium. So you may not have a hypokalemic episode when you use this combination. And the next question would be, what dose of chlorthalidone is appropriate from minimum to maximum? He has already told it is effective as low as 6.25 milligram. You can go up to 25 milligram. We won't require a 50 milligram like we use in hydrochlorothiazide. And there is another question from Dr. Anil Malhotra from Punjab. Is chlorthalidone 12.5 milligram with telmisartan good for renal compromised patients above 60 years? Dr. Narasa Raju.
Yeah, the usage of thiazide diuretics in moderate renal dysfunction is okay, but when it comes to severe renal dysfunction, there's actually no role for thiazide diuretics as as an antihypertensive. So for people who have hydrochlorothiazide as such, we've been discussing that you have to avoid and try to switch over to chlorthalidone. For up to moderate renal dysfunction, it's okay to use the diuretic. And in fact, diuretics are not acting as diuretics. And please, we have to remember and keep it in mind. They're acting by some vague mechanism on the peripheral vascular resistance. So in fact, they are probably effective even in mild to moderate renal dysfunction. Severe renal dysfunction, there's no data, and hence in severe renal dysfunction, it's usually not a choice, because by the time somebody goes to severe renal dysfunction, either he's on a loop diuretic or some other sort of a diuretic, and we normally don't use the thiazide diuretics in severe renal dysfunction.
Dr. Pradeep Sahai from Bihar has asked, hypertension assessment is often complicated by white coat hypertension and office hypertension. The second reading is often not taken. Should we use anxiolytic more often to help in the diagnosis? should we use chlorthalidone regularly in the elderly with systolic hypertension? The first half of the question I will answer. Anxiolytic, how long can you use? In the original days, if you recall in 70s, when a person comes to have a BP, they used to say, you give him for 5 days some anxiolytic, like those days Compos was available. So they used to give diazepam for 5 days and then check the BP. Today that practice is gone. You have to treat the patient for the day-to-day life. See, in the day-to-day life, he is exposed to so many stresses, and straight away take the BP, don't give any anxiolytics. Now, Narasa Raju will answer the second part. Should we use chlorthalidone regularly in the elderly with systolic hypertension?
Yeah, the second part of the question, the usage of diuretic in general for elderly people. Very elderly people, in fact, I tend to avoid using because of practical issues. See, many times when they're like 75 plus or close to 80, uses of, though the guidelines recommend diuretic usage, the usage of diuretic is like a double-edged sword in this group of patients, because they tend to produce hyponatremia, they tend to elderly people are in general poor eaters, and such sort of elderly people I tend to avoid. But active, otherwise, active elderly man, I tend to use with the caution that we keep checking the, sodium and the potassium regularly, because once the elderly go into some kind of hyponatremia and some kind of, dullness, that's usually regarded as age-related dullness, and people tend to miss hyponatremia. Once or twice we had some patients getting admitted with severe hyponatremia, and the reason being the patients being on an hypertensive, which is a diuretic, and in combination with that the restriction of sodium in the diet. So some of the people tend to restrict sodium very much, and then they keep taking diuretic. Such sort of elderly people I tend to avoid. So you have to choose the patient and then give diuretic. You have to be very cautious, and you should be monitoring the hyponatremia part. And regarding the first part also, anxiolytic, I don't think, suppose somebody, we suspect that somebody has, office hypertension, and it's mostly like a white coat effect. Better would be to go for a 24-hour home BP monitoring to, really assess this. And in some patients, selected patients, young people especially, I tend to give beta blocker to take care of this sort of hypertension.
I think we will finish with one more last question. The other questions we will take later, because we have to listen to Professor Sethi on his diabetic lecture. The last question, I will combine two questions from Dr. Abdul from Latur. Chlorthalidone as first-line agent over amlodipine. And Dr. Anuradha Govindarajan from Chennai, is CTD used as a combination drug or can be used singly as an initial drug? You can comment on this, and then we go to the next lecture.
Yeah, the CTD can be used as a single agent, especially with the elderly, defined as those who are aged more than 55. In fact, if you look at the ABCD, so-called ABCD algorithm, B is now not there anyway, ACD algorithm, one of the choices for people who are more than 55 years is diuretic. So those who have mild hypertension, the hypertension ranges being like 140, 150 systolic, or the diastolic between 90 to 100, you can use CTD as a single agent at 6.25 milligrams, but you need to wait for a time, because the antihypertensive efficacy is not seen immediately. You need to wait. It is not like in antihypertensive management, I see wrongly, many people tend to increase the antihypertensive doses at 1 week intervals. No, there's nothing like a super fast, BP reduction when it comes to practice. It has to have, either drug, any drug you give, you have to wait for 2 weeks. Like that, you start CTD, wait for at least 2 weeks, look at the BP readings, and then take a call, because it takes some weeks for diuretic to act as a single agent and produce antihypertensive efficacy. Thank you.
Thanks, Dr. Narasa Raju. There are a lot of questions pouring in. Unfortunately, we cannot take up all the questions right away, because Professor Bipin Sethi is waiting, and we have got only another 30 minutes or so to go. And I would like to invite him on the lecture on HbA1c. What is the sanctity about HbA1c of 7 or whatever it is? He is going to tell us. Because when a patient comes, a diabetic patient comes, when we ask him to have a fasting and postprandial blood sugar, he happily, even if it is me, what I will do, I will take one portion less tonight so that my fasting is good, and one portion less tomorrow morning in the breakfast so that the postprandial is good. Not only I am cheating myself, but also the doctor and also my health. And this is what happens with most of the patients. Many people for 1 week, they will be very, very careful and bring a good result. So to avoid this error, because hyperglycemia, chronic hyperglycemia, and glycemic variability produces all cardiovascular complications. So the diabetologist found another method. What is changing once in 3 months? To find out the 3 months control, they introduced this HbA1c, that is glycosylated hemoglobin level. And what is the normal glycosylated hemoglobin level in the general population? What it should be in ages above 70 or frail old people, not strong old people, in frail old people. To discuss all these things, we have an excellent, eminent endocrinologist, Dr. Bipin Sethi, to tell us all these details. Welcome, sir.
Thank you, sir. Thank you for the nice introduction about the topic. I'll just take a minute to share the slides. Just give me a minute. I hope the slides are visible. Are the slides visible, sir?
Yes, sir, it's visible, sir.
So as
yes, sir, your slides are visible. Please switch on your video.
Sir nicely remarked, HbA1c was originally discovered as a chance finding, wherein there was a difference in electrophoretic pattern in certain individuals, and it was found that it was more with the diabetics, and therefore there arose the need for additional parameter for checking the way the blood sugars have been. As the chairperson remarked, patients may make modifications in their diet, or they forget to take the medication on the day that they wanted to do the post-meal values, and they will attribute the changes in the fasting to the varying function, which luckily is not occurring nowadays, which they have attended recently. So we want to have a summated retrospective effect of the previous glycemic discussions, and we found that in HbA1c. Since we know that the HbA1c lowering of different agents is also different, we started using it as a parameter for choice of agents. As in, most of the guidelines by ADA say that if the HbA1c is more than 10, these individuals are unlikely to respond to any oral antihyperglycemic agents alone, and they would require insulin. The ACE guidelines say that if a patient is having HbA1c more than 9 and is symptomatic with polyuria, polydipsia, polyphagia, and the works you have, then you should choose insulin in addition to the other agents. So this was additionally used as a parameter for the choice of agents. Then it was found that it is also useful as a diagnostic tool. For some reason, the Americans do not like this fasting. So for their patients to come to the clinic for the fasting or to give a postprandial value or a post-glucose value, it was difficult. So outside the domain of gestational diabetes, they have largely taken away or done away with the GTT. And they say that HbA1c normal levels are below 5.72, less than 5.7. The patients who have got an impaired glucose tolerance or impaired fasting glucose, what is now called pre-diabetes, have ranges between 5.7 to 6.49, and a value of 6.5 or more is considered diagnostic of diabetes if it is repeated on 2 occasions or found to be elevated with one elevated fasting plasma glucose value. In a symptomatic patient, of course, if it is more than 6.5, one value is enough. So we moved from a marker of glycemic control to choosing one drug, 2 drugs, or insulin, and also as a tool for diagnosed diabetes. That is good. And as Sir remarked, that the HbA1c targets have been kept at a level which is comfortable for the tissues and comfortable for the patient. There were 2 landmark trials, one in 1993, DCCT, which was done in type 1 diabetics, and then the UK PDS, which published its results first in 1998. They showed that if you have better glycemic control with intensified regimens, reduction in HbA1c significantly decreased the rate of development progression of micro and, if instituted early, macrovascular complications of diabetes. This part will come to shortly. And therefore, it was recommended that patients should be aggressively treated. These studies showed that the relationship between HbA1c and complications were linear, as in, if you have an HbA1c of 10 and for some reason you cannot get it to 7, it's okay if you bring it to 7.5 because you will have a benefit of 9 more than 10, 8 more than 9, 7.5 more than 8, 7 more than 7.5. The further lowering of HbA1c from 7 to 6 in DCCT was associated with greater reduction in microvascular complications, but the risk reduction in this particular slope was less than that of the slide that you had from 10 to 7. The legacy effect of the Wikipedia study, which I was alluding to when we said there was a decrease in macrovascular complication, demonstrated that in a population that did not receive optimal glycemic control versus intensified glycemic control, there was a reduction in the microvascular complication during the core part of the study. Following the discontinuation study, these people were followed not as strictly as in the trial, but they were followed on telephonic visits. And 10 years later, in 2008, they found that subjects who had good control, obviously over a period of time, deteriorated in their control, and the subjects who were having poor control also at the end of 10 years had almost similar results, because the so-called good boys also became bad boys, and at the end of the trial, HbA1c were the same in both the groups. However, the reduction in HbA1c in the first part of the study led to some kind of a metabolic memory, which was the term coined by the Americans for the type 1 study, the EDIC trial in DCCT, saw to it that these people did not just have lesser microvascular complications, but lesser macrovascular complications in the extended phase, not in the first part of the study. So it is important that we control people in the initial part if we have to. It's like relationship between India, China, India, Pakistan, daughter-in-law, mother-in-law. If you do anything in the beginning, it is good. Afterwards, after 10 years, if you do something, nothing is going to happen. However, if you intensify therapy, the risk of hypoglycemia, obviously in type 1 diabetics, certainly it's going to happen because you're using insulin, it increases exponentially. And therefore, if you choose a target of 7, you have the reduction in the long-term risk and immediate risk of hypoglycemia. In the disease study, as you know, no subject had any adverse consequence because of hypoglycemia, but one subject was driving a car, hit somebody on the road, which led to 3 deaths. So they were not related to the individuals who were taking it, but they causing an accident. The major limiting factor in glycemic management of diabetes was and continues to be hypoglycemia when therapies, which include drugs that can cause hypoglycemia in and by themselves, are in place. And the guidelines of the ADHD has marked many parameters, but hypoglycemia is very important over there. For example, you have issues of longevity, the disease duration, and the comorbidities, possibility of diabetic complications. But if you have a young person, they say that you go for more stringent control. If the person has got an older person who is not having family support, you go for a less stringent control. Otherwise, you aim for HbA1c 7. But what is the difference in control for a younger old person with MI, non-MI, renal dysfunction, non-renal dysfunction, is the propensity of hypoglycemia causing problems, and it being unrecognized, leading to disastrous consequence if the person is living alone and does not have any family support. As the chairperson remarked, there are differences in the HbA1c cutoffs for the elderly, wherein they say that the goal should be less than 7.5 for people in good health. If the people are in poor health, you can keep it 8.5, and if somebody is intermediate, then you should keep the target of around less than 8%. But in the drugs that may cause hypoglycemia, you have a more looser targets because you do not want hypoglycemia to happen. The guidelines recommend that in HbA1c target of about 7 should be there for all non-pregnant type 1 and type 2 diabetics. ACE guidelines and American College of Endocrinology recommends a target of 6.5 if it can be achieved safely. The American College of Physicians threw a spanner in the wheel by stating that a target of 8% is safer and more realistic, because they were saying that other therapies are costly and you should continue to use drugs that cause hypoglycemia. So they were talking what essentially was nonsense. And I think all of you had messages coming from patients saying that Americans have said the target is 8. Americans say many things. Donald Trump says many things. Doesn't mean that it is okay. And they were at loggerheads with Endocrine Society and AD. Finally, a lot of debates happened, and people agreed that a target of 7 or less is important. So the singular reason, as I told you, for this HbA1c target is the high risk of hypoglycemia. And all the guidelines recommend that you should sort of individualize targets based on comorbidities and risk of hypoglycemia. See, why are we trying to control diabetes? So that you don't get long-term complications. If somebody has got CA lung for stage 4 with mets in the brain, how does it matter if his glucose levels are 97 fasting or 120 fasting or 170 fasting? Because by the time he's going to develop the complications, he has to go away. So if he wants to eat an ice cream or a chocolate, please don't ask him to stop doing so. In fact, we ask patients to share also with us. The limitations of this target are these. The target cutoff HbA1c, which the chairperson had very smartly told in the beginning, is 6.5. So you are diagnosing at 6.5 and letting the patient be up to 7. So what sort of irony is this? It denies the patient the opportunity to have additional benefit, which we told you that from 6 to 7, there was a reduction in the complications, but this reduction was not considered appropriate because the benefits were not as good as the harms caused by hypoglycemia. And we know that if the lower the HbA1c level, the better is going to be the outcome. So why not give this? This is because we have, I'll have reshared the slide. There is some problem there. They're stuck again. Just permit me a bit. Okay, just a minute, sir. While we fix that up, we will. I'll tell you that why we are wanting to change this kind of therapeutic nihilism that we have. Oops, this is stuck again. Just a minute. Please give me some time. This nihilism results in underusage of the drugs. We gone are the days when we were using sulfonylureas, magnetinide, and insulin, wherein hypoglycemia was a distinct possibility, and we had to avoid it at all costs. Now we have agents which give us possibility.
So you need to share your slides, sir. Please share the screen once again.
I'm trying to share them. There is some issue. The slides are stuck. Give me a moment. Right. The UTPDS was restricted to available drugs because at that time they had hypoglycemia, and when you wanted to use good glycemic control, you either use insulin or sulfonylurea. Both of them inherently cause hypoglycemia. So this target is acceptable and still valid when we are using a sulfonylurea or we are using a drug like insulin. But this target is not so good when we have got newer agents which are good in not just reducing the HbA1c, but also producing some benefits beyond that because they do not produce hypoglycemia. Therein we have DPP-4 inhibitors, alpha-glucosidase inhibitors, and SGLT2 inhibitor. These drugs can promise the can I request the moderator to share the slide?
So now click on the screen and use the arrow keys to shift your slides. First click on the screen, sir.
Now we have diabetic agents which do not ever cause the hypoglycemia, and the prioritization of safety over control has been carried for too long. We know that people with HbA1c less than 5.7 do never separate from microvascular complications of diabetes. So why not we aim for a good control? And if few KPDs is to go by, there is going to be decline in the beta cell function. So why can't we offer good therapies with lower targets for individuals who present to us at diagnosis? This is our two purposes. A, you can go as low as you want, almost to the non-diabetic levels. B, you would have protected tissues when they require protection the most. You also know that the compliance, the control is going to deteriorate with time, but that's not going to be an issue. If you can control them initially without fear of hypoglycemia, then I think HbA1c can be as low as you can. Most of us treat diabetics. If we have a phone call from a patient who is on metformin who says that I'm having sweating, I'm having palpitations, we tell him it is not low sugar reaction. But if in addition he's on glimepiride, he's on glycoside, we tell him, okay, you check your sugar, but reduce your dosage. Why? We are as afraid as the patient of a hypoglycemic episode. The way forward would therefore be to reconsider the target. The new goal could be 7 to 6.4 or even lower. And one should have separate algorithms for lower HbA1cs for patients who are not on drugs that cause hypoglycemia. That is metformin, alpha-glucosidase inhibitors, SGLT inhibitors, DIP4 inhibitors, GLP-1 analogs, and the SGLT inhibitors. There have been some baby steps in this direction. There was a study by DiFranzo wherein they combined pioglitazone, metformin, and GLP-1 analogs and found that the patient had excellent control, HbA1c below 6.5 without hypoglycemia. And this was one study which supported the durability of exenatide. The verified trial has tried to look at HbA1c lowering by two drugs, vildagliptin and metformin, to begin with, in individuals who can be controlled with one drug. That is HbA1c between 6 to 7. And then they found that people who are on these two drugs to begin with, they had lesser chances of requiring another agent. 50% of them did not require another agent for 5 years. This trial did not look at the outcomes which are being analyzed, but it tells that you can safely get to the target and yet not have hypoglycemia. The final remarks, as I said, we wanted to put a provocative concept. All of you are experts, and I find that there are people from Chennai who are experts from, let's say, genetics, from Vishwanatham sir's days and from the days of Madras Medical College, Stanley, in treating diabetes. So I cannot teach them anything new. The evidence in terms of outcomes for this concept that I have put forward to you is exciting, but currently lacking. This approach certainly will incur additional costs and applies to patients who are not on insulin, sulfonylureas, or meglitinides. Prevention of diabetic-specific complications should serve as a reassurance, and the investment, I feel, should be worth the effort. Thank you very much, and I do apologize for the little problem that we had, not little, lot of problem that we had in sharing this slides with you. Thank you very much for your patient hearing.
Thank you, Dr. Sethi. That was a wonderful concept. Actually, it's very nice that you have set people to think if up to 5.7 is normal and 5.7 to 6.4 is also diabetes or pre-diabetes, why set a goal at 7? As he rightly said, all these years, that science is every day changing, and we should change according to that. And the nice concept that he has put is non-diabetics do not have microvascular complications. That means non-diabetics whose HbA1c is below 5.7 never have reduced the future complications, because the incidence of diabetes is ever increasing in this country, and therefore the complications of diabetes, which is mainly cardiovascular, diabetics are 2 to 5 times more prone for any cardiovascular illness, be it stroke, be it myocardial infarction, be it peripheral arterial disease. So can we prevent all these things by reducing HbA1c to ideal levels? As he says, around 6.5 or between 6 to 6.5 would be fantastic. That's a very good, nice thinking, sir. There are a lot of questions that you will have to be answered. Dr. Syed Yusufali from Kammam has asked, what are the good oral diabetic drugs in diabetic nephropathy with insulin?
Yes, you are right. Traditionally, people were using insulin, but it is possible to use many oral antihyperglycemic agents. Metformin can be used up to GFR of 30. 30 to 45, do not initiate, but you can continue at half the dose that the patient was taking. Above 45, you can continue, monitor renal dysfunction, and give the full dosage that the patient can tolerate, and is maximum prescribable dosage. DPP-4 inhibitors are other agents. GLP-1 analogs, I'm talking about the non-hypoglycemic producing agent first. You can also use sulfonylureas. You can use alpha-glucosidase inhibitors like acarbose up to GFR 26. So there are many agents which you can use in individuals who are having end-stage renal disease. Insulin is, of course, a possibility in any diabetic, but it is not necessary that the mere diagnosis of diabetic nephropathy with CKD stage 3 is an indication for stopping all antihyperglycemic agents. Sir has also beautifully remarked, many a times we say this drug is costly. What is the cost of reaching a hospital in the non-COVID days also with hypoglycemia? The fear that the patient's family has, and the duty doctor promptly says, if you had not come in half an hour, your doctor would have killed you with hypoglycemia. And the expenditure in the hospital for treating hypoglycemia is far in excess of the safer agent which Sir had mentioned. I am not talking about the goodness and utility of SGLT inhibitors and GLP-1 analogs in ASCVD, heart failure, and renal failure. That is not the topic of discussion today. When we talk about cost, we only talk about cost of purchase of medicines, not about the fear of hypoglycemia, which if you tell me that I am putting you on a drug that can cause hypoglycemia versus non-hypoglycemia, I will choose. At least give the patient a chance to choose the drug. We don't even give the chance. We assume that the patient cannot afford, whereas patient can afford to buy 2 people like us.
Next question is to cardiologists. What are the good oral diabetic agents in heart failure with preserved ejection fraction? I think Narasa Raju will agree. Till today, there are no definite drugs for the treatment of heart failure with preserved ejection fraction. But one thing I can tell you is, what are the good oral anti-diabetic drugs in heart failure? If we stop in the first half of your question, most of the drugs are not friendly. All these anti-diabetic drugs that are available right from insulin up to date, they are not patient friendly as far as heart failure is concerned. That is why in 2008, the Food and Drug FDA said you should have a CVOT trials whenever a new drug is introduced, and gliptins first pass the test. Even among DPP-4 inhibitors, saxagliptin and alogliptin are not allowed to be taken. Only the other gliptins are safe in cardiac failure patients. And SGLT2 is a promising drug in patients to prevent heart failure, not only in diabetics, but also in non-diabetics. And that is where we stop as far as preserved ejection fraction. As far as preserved ejection fraction is concerned, till today there are no drugs, even though DAPA-HF says even in patients without diabetes, this drug may be useful. So we have to wait and see whether this drug will show any usefulness in the treatment of heart failure with preserved ejection fraction. I would like Professor Sethi's comment on this, sir.
Yes, sir, I agree that heart failure, though I'm not an expert in this, with reduced ejection fraction, even the drugs which are proven, the neprilysin inhibitor, they are also not shown to be very effective in the trials that have been published. The preserved ejection fraction, we have got very little choices, but we do have a good choice in SGLT inhibitors, provided the GFR permits, in not just diabetics, but also non-diabetics. And as the respected chairperson pointed out, dapagliflozin has been approved for use for treatment of heart failure by DCGI, even in the absence of diabetes. So now we will have more of nephrologists and the cardiologists who will be prescribing these drugs, because they, whatever they prescribe now, patients say, I will take it. So when you poor people like endocrinologists write a drug, sir, what is the cost, sir? How much, sir? How long we have to take? But you people write PCSK9, says, how many times I have to take, sir, per day? Only 15 days. Only 15 days, I will take it. So I think then these drugs will really have a good this thing, and we are happy. Whoever prescribes, the patient is benefited.
Sir, you got another question. What is the maximum dose of DPP-4 in cardiorenal syndrome?
Well, actually speaking, most of the DPP-4 inhibitors are a single dose phenomenon. That is, you feel it, shut it, and forget it. Either they work or they don't work. When I say that, certain drugs like sitagliptin requires dose modification. Saxagliptin requires more dose modification. Alogliptin also requires dose modification, and also vildagliptin in patients with renal insufficiency. So people who cannot remember all these things, pharmacology is a different subject, difficult and different subject. They say, okay, I will use teneligliptin, linagliptin, or the new ebilogliptin, because no dose modification is required. So having said that, whatever the dose, it's a single dose phenomenon. If it works, it will work by doubling the dose, taking it twice daily, thrice daily, it's not going to change. So in patients who've got cardiorenal syndrome, as the respected chairperson pointed out, the ESC guidelines recommend the use only of sitagliptin and linagliptin because they have got dedicated trials in Tecos, Carmelina, and Carolina. Other agents have actually got a label saying do not use saxagliptin. So if you're choosing any of these agents and the patient's creatinine is permitting, that means GFR is up to 50, you can give full dose of say sitagliptin. If it is 25 to 50, give half the dose, otherwise give 1/4 the dose. So the dosage has to be reduced. There is no need to increase the dosage. You can safely use this. There is enough data to say that they do not worsen heart failure.
There's another question to you, sir. What are the oral anti-diabetic drugs to be prescribed in elderly females?
Why only females? You are not partial to males.
I don't know. That's a question.
Okay. In here, we have to take into consideration three things. One, what is the longevity of a person? See, our Prime Minister is 65 years old. All our leaders are more than that, but they are doing their work this way or that way, whatever it is, but they're working. So every 60, 65-year-old person is not the same. You have to find out how active he is, what is his mental status. Does he forget his pills? Does he require less number of pills? Hypoglycemia, if you can avoid, if you have the possibility of controlling the sugar with two agents, choose a non-hypoglycemic producing therapy. So answering your question, metformin, B4 inhibitors, if possible, SGLT2 inhibitors, alpha glucosidase inhibitor, these drugs will gain preference and they should be given. I often ask this question again very provocatively. What drug will you take after metformin for controlling hyperglycemia? I think the answer will give you the answer that you should use for the patient. At least discuss with them. Let them not be imprisoned with your thought process. Give them options, and then they may not like this idli dosha, they may like burger, they may like the pizza. So you ask them, but tell them what the advantages. So avoid hypoglycemia. The answer is that there would be some problem of genital mycosis in elderly people, and in elderly males, problem with BPH. You can discuss this option, doesn't occur in all the people. Use non-hypoglycemic producing drugs, which can be given in a single dosage, which are safe in renal dysfunction, which do not cause renal dysfunction, which do not cause heart failure. See, why pioglitazone we are not using now? Sir very nicely mentioned very few drugs which can be used for protecting the heart, but for causing heart failure, you have got one. That is pioglitazone for sure. So don't use drugs which can cause these kinds of problems, and then you will be fine.
I think as sir said, I would agree with him. It is not the age. Is that age above 65 or 70, you call it elderly. If the person is frail or person is strong. If he is going to be like our touchwood or like our Prime Minister, you can use any drug. Because you will not have a fear of causing hypoglycemia. And even if there is a hypoglycemia, they overcome that very easily. Whereas a frail person goes in for hypoglycemia. That is 65 plus itself. There are a lot of very weak, very frail persons. Pulling them out of hypoglycemia is very, very difficult. And therefore, it is better to treat them differently. In them, as sir said, give metformin and SGLT2 inhibitor so that you will not push them into hypoglycemia at any part of the time. So that is how we should look, not at the age, but at the physical nature of the person. Where if he is robust, walking about, doing day-to-day activities, first class. We hear that there are 95-year-old COVID patients going back home and 30-year-old obese adult succumbing to the disease. So it all depends on the fitness of the person that you should use. The reason is hypoglycemia should be avoided at any cost. Now, there is a whole discussion today. Sir has put in a wonderful thing. Why not you think of reducing between 5.7 to 7 instead of keeping it at 7? So the whole point is, if you will not produce hypoglycemia, please go ahead and correct them. And I think we have had a wonderful discussion on hypertension and on diabetes. I should thank the organizers, Dr. Bipin Sethi and Dr. Narasa Raju for their wonderful contributions. And Thanks, Johnny and Sachin Nair, for having brought us together. Thank you.
Thank you, Dr. Sivakadaksham. It was excellent moderating session. I'm sure it has been really helpful for all doctors. And thank you, Dr. Bipin Sethi and Dr. K. Narasa Raju. It was really a academic feast, and I can tell the content and the session what we had. I'm sure many doctors in India might have really benefited by your session. And I thank all of you for being part of this session and giving valuable time. And thank all the viewers across India for being part of the session. In fact, sir, we almost had 1,000 logins today, and I'm sure we will have more such sessions with the doctors across India and give you valuable insights. Thank you once again, sir. Thank you very much for your valuable session, and thank you very much, sir.